I'd like to introduce our speaker today, Dr. Aurelia Wood. Dr. Wood has returned back to Louisville recently and NCMG. She is now a faculty member in the Division of Endocrinology at Norton Children's Hospital and assistant professor of pediatrics at the University of Louisville School of Medicine. She obtained her medical degree at Wright State University in Dayton, Ohio, and completed her pediatric residency here at the University of Louisville and Norton Children's, where she was also served a year as chief resident. She then did a pediatric endocrinology fellowship at WashU in St. Louis, and she came back this last summer, and she continues to work as a clinician educator and leader in school health and health equity. She's going to talk to us today about something that she's passionate about, and that's addressing inequities in pediatric type 1 diabetes care. So Dr. Wood, I'm going to turn it over to you.
All right, good morning, everyone. Can you all hear me?
Yes.
All right, perfect. Thank you for that warm welcome, Dr. McDonald, and thank you all for joining us today. Please feel free to put questions in the chat so that they can be answered and addressed at the end. But the title of my presentation for today is Areas of Opportunity to Address Inequities in Pediatric T1D Care. The objectives for today will be to understand the changing landscape of pediatric type 1 diabetes care, to understand the inequities that result in disparities in outcomes, and then to recognize the role of primary care clinicians in diagnosis, collaboration in management, and then mitigation of those inequities. As we know, type 1 diabetes is a chronic autoimmune condition that is due to autoimmune destruction of the insulin-producing beta cells of the pancreas. Type 1 diabetes occurs in individuals who have a genetic susceptibility to developing this autoimmunity, which for most patients is due to defects and differences in the HLA region on chromosome 6, which encodes surface level proteins important for immune regulation. Though we don't know exactly what triggers the immune process, we know that these susceptible individuals experience some immune inactivation and activation that results in the production of diabetes autoantibodies. And once at least 2 of those autoantibodies are present, we classify that as stage 1 of diabetes. This is the early stage where patients don't have symptoms, don't have abnormal blood sugars, and typically don't know that they are at risk for or have developing diabetes. Once that immunity progresses and beta cells are further destroyed, blood sugars become abnormal. Typically, again, patients are not aware that they have diabetes because they're not yet having symptoms. So once those antibodies are positive and symptoms progress and are detected, that is when we call it fulminant stage 3 diabetes, which is when we meet most of our patients. The diagnosis of diabetes can be made in a couple of different ways based on serum lab testing, as noted on the right side of the slide. So fasting blood sugar of 126 or higher, a postprandial or 2-hour post-oral glucose tolerance test blood sugar of 200, or an A1C of 6.5 or greater in a patient who is having the symptoms of hyperglycemia and an anabolic state, which includes those that we're familiar with on the left: polyuria, polydipsia, nocturia, bedwetting, especially in a previously potty-trained child, sudden weight loss, and fatigue. Because of those presenting symptoms, there are many other labs that may be obtained at the same time, which, while suspicious for diabetes, are not in themselves diagnostic. This includes isolated glucosuria, which can be seen in fever, exercise, Fanconi syndrome, proximal tubular injury; isolated ketones, which can be seen in a fasting state or due to dehydration; and asymptomatic hyperglycemia once. This could be due to stress, this could be due to being in a postprandial state, or it could be iatrogenic, which we often see for patients who are taking steroids. Insulin levels are sometimes obtained as well, and while may be helpful in differentiating between types of diabetes, if it's not clear whether it's type 1 or type 2, these themselves are not diagnostic and may just reflect insulin resistance, a fasting or postprandial state, but typically for making the diagnostic are not significant. And finally, the symptoms of diabetes, of course, should prompt investigation of blood sugars, but if they're normal, should expand that differential to include central diabetes insipidus, hyperthyroidism, hypercalcemia, and then some non-endocrine conditions such as nephrogenic diabetes insipidus, primary polydipsia, or just a behavioral change. But remember, to make that diagnosis, we need one of those blood sugars and we need those symptoms. Diabetes affects persons of all ages across the entire world, but does, of course, have that predilection for ages 10 to 17. The highest prevalence and incidence of type 1 diabetes is actually in Finland, followed by Norway, Sweden, and Algeria, Spain, the United States, New Zealand, and Australia. Here in the United States, we have data from the CDC from 2019 to 2021 that tells us there were over 300,000 children living with diabetes in the US during that time frame. Average age of onset, 12 to 14 years, with the highest prevalence in non-Hispanic white populations, which is not surprising given the worldwide distribution. The incidence currently is about 30 to 35 per 100,000 youth and has steadily increased between 2002 and 2018, specifically with the highest rate of increase in non-Hispanic Asian or Pacific Islander youth, or those who identify as non-Hispanic, Black, or Hispanic. The treatment of type 1 diabetes has, of course, focused on stage 3. Once we know someone has diabetes, has that hyperglycemia, and needs initiation of insulin and blood sugar monitoring. One of the new mainstays of blood sugar monitoring is the use of continuous glucose monitors. So these are devices that are worn continuously on the skin that have a small little filament, the glucose sensor that goes into the subcutaneous area and measures the sugar that has diffused from the capillary into the interstitial fluid. These devices have high and low alerts, both for real-time and predictive patterns, letting patients and families know whether they're expected to go high or low. They connect with a compatible receiver or smartphone and some with a smartwatch to show that data transmission. And the data can be uploaded and saved into a cloud, which allows for following apps. So friends, families, teachers can follow the patient's CGM monitorings. And it also allows us as clinicians to be able to evaluate their data both in clinic and then between appointments. There are multiple different CGMs available on the market at present, probably many that you're familiar with or have seen on your patients. This includes our Dexcom G6, Dexcom G7, Medtronic Guardian, and the Libre 2 and 3, all of which are approved for use in pediatrics. Data on CGM has been overwhelmingly positive. The InControl, Diamond, Gold, Impact, and HypoDE are all large-scale national randomized controlled trials, and all of them had very positive impacts, showing decreased hypoglycemia, improvement in A1C, and improvement in quality of life for those using CGM as compared to meter sticks. Insulin pumps have been around for now about 20 years or so, and as we know, deliver continuously short-acting insulin to provide that basal background insulin, replacing a long-acting insulin, and then our program with the patient's insulin doses for carbs, hyperglycemia correction, blood sugar targets. Because of the technology and the ability to deliver insulin via these tiny little micro chambers, doses can be delivered up to increments of 0.025 to 0.05 units, and it allows for really tailored insulin delivery. Clinical outcomes for pumps similar to CGM have also been overwhelmingly positive, with large-scale studies showing improvement in A1C, improvement of quality of life, reduction of hypoglycemia, and safety and efficacy even in the youngest of our patients. Automated insulin delivery has emerged in the last 5 to 10 years, and this is where we have the integration of a compatible CGM and pump that allows for modulation of insulin delivery based on those predictive CGM patterns. There are a number of different devices that are currently available, all of which stem from the pumps that the pump companies that were already FDA approved for pediatric use, and each have a different algorithm that allow that functionality to help modulate blood sugar patterns in order to increase time and range and improve glycemic control. The two main features of all of those algorithms is predictive low suspend, where insulin is stopped or decreased significantly to try to mitigate or prevent lows, and then hybrid closed loop, which is where the insulin delivery is increased or decreased based on those CGM predictive patterns in order to keep the patient at their desired target range. We are working towards and hopeful for eventually a fully closed loop system, as the current systems still require patients to enter in their carbohydrates, pay quite a bit of attention to their patterns, where a fully closed loop would be something that you kind of set it and forget it and don't have to put any input from the user. The first FDA-approved hybrid closed-loop device system was the Medtronic 670G. This was approved in 2017 for children 14 years of age and up, and worked to adjust insulin every 5 minutes in order to keep blood sugar at the target of 120. In 2019, the Tandem company was able to get approval for the t:slim X2 Control IQ technology for children 6 years of age and up, which has the features seen here and a nice touchscreen on their existing device. It utilizes two main features, which is the basal suspend, again, to mitigate those lows, and then increases, decreases, stops, or delivers a bolus based on blood sugar patterns, as noted here in this simple algorithm. They also have different activity settings for both exercise and sleep to achieve specific glycemic patterns during those times to overall improve glycemic control. In 2022, Gloco was able to obtain approval for the Omnipod 5. This is our one patch pump, our one tubeless pump, and is approved for ages 2 and up. It is compatible with the G6 and as of this month, the G7, and it's managed by a controller and now is also able to be managed by an app. Its system is similar to the Medtronic in that every 5 minutes it modulates insulin delivery toward a customizable blood sugar target between 110 and 150. t:slim released last year for ages 6 and up the Mobi device, which is seen on the right side as compared to the t:slim, which is currently the smallest insulin pump device that's available and has a variety of tubing lengths that it can be worn similar to a patch pump with this sleeve if desired. One of the newer companies that has obtained FDA approval as of last year is Beta Bionics for their iLet pump. This pump also integrates with the Dexcom CGM. However, it doesn't require carb-specific entry. It just requires the user to input meal announcements. So telling it whether it's eating a normal meal, a large meal, or a small meal. And the only input that's needed is the weight of the patient. So no specific initial settings. And they've also released now a newer iLet color that will be integrated with the G7 and then the Libre Plus. Finally, the newest FDA-approved device is the Medtronic MiniMed 780G that was approved in January this year, approved for ages 7 and up, very similar to the 670, but we are told has a much better sensor and some other functionality that improves safety and is more aggressive in blood sugar control. So we have some data now that we've had these devices available for almost 10 years that also show, as expected, improvement in rate of hypoglycemia, improvement in A1C, really great feedback from families and patients alike on ease of use and quality of life, and showing lots of improvement in terms of time and range. One other aspect of diabetes care is addressing severe low blood sugars, which we do with glucagon. Many of us are familiar with the initial glucagon kit that requires reconstitution of glucagon in liquid. However, we now have 2 newer types of glucagon that are much more user-friendly and easier to use. That includes Baqsimi, which is a 1-dose nasal spray approved for kids 4 and older, and then Gvoke, which is a pre-mixed glucagon that either comes in a pre-mixed injection or hypopen, similar to an EpiPen. And there are lots of other diabetes types of tech for patients that may not be yet using or may not be ready yet to use a pump, including smart pen devices and then smart auto devices. So really, CGM, pump, and hybrid closed-loop systems, because they're safe and effective, and there's many different options that we now have to offer, are starting to become somewhat the standard of care for diabetes. So what is the pathway to getting to that diabetes tech and successful long-term use so you can enjoy all of those benefits? Well, first, you've got to have open communication with your endocrinologist between the family, got to build that therapeutic relationship, have shared goal setting, have ongoing education so that you can feel confident that they'll be successful and be able to handle their pump, so you give them that prescription. Once that prescription is given, we need insurance to approve it. We need to be able to obtain the device, complete initial and ongoing education so that we can have those positive outcomes. However, each one of these steps does pose potential barriers. The first being getting that prescription from your physician or diabetes clinician. So the American Diabetes Association gives us some tools and thoughts on some basic things we can consider when we're approaching thinking about a pump for our patient. They say to consider their specific needs, their levels of skills and their diabetes education, and the available devices and how they may be beneficial for that patient. In terms of making the step to initiate it, want to make sure the patient and the family are both ready. We need to make sure we chose a pump that we think they will be successful with, make sure that the pump is able to deliver and have settings that are appropriate for the patient, and then ensure that they have been pre-educated on potential complications, how to make the transition, and then also have some awareness of some of the advanced features of the pump that may be beneficial for them. So really kind of general. So a lot of that comes down to personal factors, individual factors, kind of knowing your patient. And for each one of us as prescribers, that may encompass different things. We may have an idea of what the model patient is for a specific device. We may have certain institutional practices and protocols that may determine how and when we initiate pump use. And we may have some hesitation for some patients, or even like lack of trust or fear of liability if they don't do well with this device. We may be concerned about insurance approval and long-term sustainability and the financial burden that might impact our patients. We may be worried if they're not able to get to clinic routinely, if we'll be able to support them adequately, that they can be successful. And there may be other factors that we're not even aware of in terms of culture, race, ethnicity, or other background that might impact us and give us hesitation towards prescribing that pump. And we know that because we have so much data on demographics and background, that these things absolutely do impact both prescribing and outcomes. So a group of researchers out of Albert Einstein in New York published a paper in Diabetes Care, one of our renowned journals, in 2022, looking at the effect of race and ethnicity on utilization of pumps and CGM. And they found that both when unadjusted and adjusted for socioeconomic status, other healthcare variables, diabetes management, whether or not they use CGM, duration of diagnosis, that non-Hispanic white patients overwhelmingly utilized CGMs and pumps at much higher rates than Hispanic and non-Hispanic Black patients. So when we account for all other factors and the one determining factor resulting in prescription is race or ethnicity, that makes us understand and need to turn our attention towards whether we have some implicit bias that is impacting those decisions. So the Type 1 Diabetes Exchange, which is a national multi-center nonprofit dedicated to QI and research that spans academic and private institutions, published data in 2021 looking at and trying to evaluate whether implicit bias exists in prescribers and then how that translates to their prescribing habits. So they enrolled 109 pediatric and adult diabetes clinicians and provided them with the Modified Diabetes Provider Implicit Bias Tool, the DPIB. So this is kind of a two-piece evaluation tool, the first of which the participant is given a list of different factors and are asked to rank them in level of importance when they're considering prescribing a pump. And the second part, they work through a clinical vignette in which they're asked to determine whether or not they would prescribe a CGM or pump to that patient. The demographics of the participants are on the right side of the slide. And the first part of the exercise revealed that most ranked very highly whether the family had preference for technology use, whether they're monitoring their blood sugars regularly, and their A1C as the highest determining factors of whether or not they would prescribe tech, with race and ethnicity and income being the lowest. However, at completion and evaluation, it was found that actually 34%, despite these results, did have race or ethnicity bias, and 61% had insurance bias. So in terms of use of CGM, this also translates into disparities in use, which again, it translates into disparities in outcomes. So in 2022, the Type 1 Diabetes Exchange published some of this data on trends in use over time as these devices have emerged, and have found that across all patients, happily and thankfully, use has increased significantly. However, the duration and magnitude of change and the ultimate disparity still existed, with over a 6-year period, non-Hispanic white patients experiencing about a 50% increase, Hispanic patients about a 46% increase, and non-Hispanic Black patients a 50% increase, which is all similar. However, the ultimate disparity was about 30% between Black and white patients. Very similar trends in pump use, with uptake increasing over time, which is very encouraging, but there's still existing this huge discrepancy of about 40% between non-Hispanic white and Black patients in terms of use of pumps in 2022. And finally, similarly for hybrid closed loops, there's about a 20% discrepancy and disparity in terms of use between white and Black patients. So these disparities in use, again, translate into inequities and outcomes. And looking at A1C, the mean improvement was the highest in non-Hispanic white patients and was the lowest in Hispanic patients, even when adjusted for age, gender, and duration of diagnosis of diabetes. And that difference still persisted even when further accounted for whether or not they're using a hybrid closed loop, a pump, or a CGM. So how do we address this? What is our best next step? So something that we've probably all been engaged in and have had the opportunity to participate is implicit bias training. And while implicit bias training does have limitations, it has been shown in large-scale studies to have impacts on institutional practice and group thinking, and then also just bringing awareness. So there is absolutely value in implicit bias training. However, because the individual may or may not still be operating with implicit bias, as we saw in the earlier study, we really need to keep ourselves and each other accountable. And so QI interventions designed to create protocols and practices that address root cause and promote accountability are really a great way to ensure that we are addressing and mitigating and eliminating implicit bias as a factor in prescribing. We also want to make sure that we're providing equitable care across different clinical locations, whether that be a rural clinic, a primary located clinic, or an urban setting clinic. We want to make sure we're screening for social determinants of health for all patients so that we're not under or over screening certain populations. In order to be culturally sensitive and ensure that everyone has the full opportunity to engage in their appointments appropriately, we need to have a variety of learning tools, make sure we have interpreter services, all of our educational materials translated into multiple languages, and we need to help our patients develop and grow their literacy, health literacy, and e-health literacy. Another source of potential bias is geography. So on the right side of the screen, you see a lovely map of Kentucky with all the little H's being adult hospitals and our two lovely green stars being Louisville and Lexington, where our large pediatric centers and most of our diabetes specialists live. And so it's interesting that there's actually a higher incidence of type 1 diabetes in person living in rural areas as opposed to high density areas, meaning that many of the patients that are not near those centers are at the highest risk. When looking at A1C, rural youth and adults have higher mean A1Cs compared to age-maxed urban peers. CGM and pump utilization is lower, and even when prescribed, utilization and long-term utilization is actually lower. So looking at this graph on the right, this yellow line is used in an isolated small rural town, which is much lower when compared to a small rural town, a large area, and an urban setting. Some solutions that have been successfully utilized to address geographic bias is creating satellite clinics and telehealth. One of the greatest examples of a telemedicine clinic is through the Barbara Davis Center, which is located in Denver, and they have an enormous catchment area. They serve all of Colorado, Wyoming, Nebraska, and Kansas west of Kansas City. So really have a huge catchment areas where patients are coming hundreds and hundreds of miles to receive their diabetes care. So in 2019, they published their study on the use of a really robust clinic-to-clinic telemedicine model, specifically looking at how this impacted tech utilization. So their study group had about 128 patients who were well matched in terms of age and duration of diabetes and mean A1C with the control group, and they lived on about 400 miles on average from the main campus, as opposed to about the 100 miles from main campus of the main group. The study design was that the diabetes clinician would be at main campus in their office connecting to the patient by telemedicine, and the patient would go to a partner clinic that was local to them, where they would be triaged by an MA, have vitals, their devices uploaded, and then have a visit conducted with the clinician that's also facilitated by a diabetes nurse or educator. So a really, really robust model where it almost probably felt like they were at main campus, and it's probably the closest you can get to what our typical visits feel like. However, despite this really robust model, they still found that there was a statistically significant difference in CGM use alone, CGM use across all users, and CGM and pump use between those who were seen at the main campus and those who were seen remotely. They found that insurance really wasn't a factor, that the main difference and the main impactful factor was the distance they had to drive, despite having this robust model of care. In terms of A1C, they found that in the dark bars that A1C was lowest for patients seen in clinic, regardless if they use no technology at all, pump alone, CGM, or a hybrid closed-loop device. And they observed that patients in person just were using tech more, and that tech use, as we expect, decreases A1C. So there's really this need for additional investigation and understanding of the needs of patients who live remote areas and on the edges of our catchment area to further explore that discrepancy. Some ways that we have began to address the needs that patients have that are being seen remotely, especially via telemedicine, is improving the virtual clinic workflow and operationalizing connectivity to platforms. So one of the things we could say COVID gifted us was an increased use of telemedicine and an increased comfort of use of telemedicine. However, for many clinics, even though this has been used for many years, it was absolutely brand new. It was emergent to be used, and some of those visits initially were not as robust or helpful as they could have been. So many studies have been done on operationalizing that workflow to make it a much more robust experience and have a better patient outcome. Many and actually all of our diabetes devices connect to web-based and cloud-based platforms. And so when we're seeing patients remotely, we really need them to upload that data and be able to engage with those platforms such that we can have objective measures to discuss in terms of blood sugar, insulin delivery, use of their devices to make sure they're getting the most out of them. And that was a huge challenge, pre-existing, but certainly a new challenge during COVID. And so some studies have been done on showing just simple QI interventions to improve that operationality that allowed patients to go from very low rates of connection to very high rates of connection. E-health literacy is also a huge part of this because it is defined as the ability to seek, find, understand, appraise health information from electronic sources, and then apply that knowledge. So there is the Norman and Skinner model of e-health literacy that really states there's 6 components that are necessary to be able to do this. The first is traditional literacy, being able to read, write, speak, and understand. The second is health literacy, so the ability to read, write, understand, and interpret medical information. The third being information literacy, which is understanding how information is organized, how to find information, and then how to use that information to share it with others. The fourth component is scientific literacy. So this is really important for those with chronic conditions such as diabetes, and that is the understanding the nature, aims, methods, and applications and limitations of creating knowledge in a systematic manner. So really understanding some of the basics of what research really means. The fifth being media literacy, so being able to place information within the social context and understand that media intrinsically frames messaging, and you need to utilize the information presented and then have further discernment to contextualize it and apply it to your own self. And finally, having computer literacy, so just the ability to use computers successfully to solve problems. So this is a little bit more complicated and a lot more involved. And I was really interested when I was reading through this information, because when you think about it, our patients are getting information from everywhere. They're getting it from the news, they're getting it from commercials, they're getting it from advertisements, they're getting it from social media. So they're getting bombarded with all of this information and then coming to clinic with that experience and their own challenges and background. So we really need to make sure that we help them to understand what e-health literacy is, but then also develop it further. Thankfully, there do exist tools to do so. One of the most commons being the eHeal scale. There's an 8-factor scale, which is the main scale shown here on the left. There's also a 3-factor and a bi-factor scale. But it has been validated in adolescent and adult populations. And there was actually a study done a couple years ago looking at elementary and middle school children in Appalachian, Kentucky. So we know that this scale can be effectively reproducibly predict whether someone does have e-health literacy. And potentially providing this tool to our patients will help us understand our population, what their strengths and limitations are, so we can then tailor education and create tools that help them improve their engagement with type 1 diabetes platforms, MyChart, but then just their general health and wellness in terms of an e-health perspective. Another strategy in addressing a geographic bias is coming to the patient. So of course, having satellite clinics is an amazing thing. However, that's a large institutional ask that is based largely probably on business practices and other metrics and more long-term goals. But some shorter term and easier methods could be utilizing mobile units to come to patients who are in lesser served areas. So St. Louis Children's Hospital actually in the last year developed a mobile unit for type 1 diabetes care, which is targeted towards the north portion of St. Louis County, which is a somewhat segregated area of the city that's primarily inhabited by people who identify as Black or African American and who experience lots of healthcare disparities. So with this mobile unit, they're able to facilitate appointments, lab screening, retinopathy screening, training for schools, and they're also able to provide some nutrition services for prediabetes, and everything is free of charge. So this is a great model that could absolutely be reproduced for rural care in other cities and states. Another really great area of opportunity is school-based health. So school-based health centers have been around since the 1960s and have many different forms. There could be the school-based health clinic that is adjacent to or attached to a school building. There are 99 here in Kentucky. It could be a telehealth model where patients are in their school and then remotely connecting with the clinician. There are school-linked clinics where there may be an in-person, remote, or mobile kind of combination type of service. And then there are primarily services that are provided mobile. While I was at Nationwide Children's, I had the pleasure and the privilege of being able to co-create and serve as co-medical director of the Diabetes and School Health Program, which is a novel school-based health equity intervention designed to help those patients who are the most vulnerable to complications, as well as their families in schools. So what we aimed to do was help to increase self-efficacy and independence for our patients, improve comfort, knowledge, and consistency in type 1 diabetes care in school, facilitate communication, and also remove barriers to common problems such as not having medications or supplies by couriering those to both school and home for our patients. So what's kind of unique about this program is that though there have been some interventions for type 1 diabetes in the school setting, most of them focus on education alone, which is vitally important. However, our intervention was clinical and kind of robust and multi-level. Now in its 4th year, by our 3rd year, we had over 1,300 visits with 103 students at 67 schools across 14 districts. They were from kindergarten to senior years at school, and majority of them identified as not Hispanic white. In the pilot year, the average A1C was 12.4, which decreased almost 2% by the 3rd year. In the initiation of the program, only 16% of patients were regularly using CGM. By year 3, 81% were. And initially, only 7% of patients were using pumps, and by year 3, 28% were. So this intervention was successful in many different ways, but absolutely in helping improve glycemic control and improving comfort and consistent use of diabetes tech. And again, is something that could be reproduced at different institutions. So now we've thought about some of the factors impacting prescribers, but what about the factors impacting patients? Because again, our patients are people and they're kids and they're students and they have their own family and cultural and other experiences that they bring to the table and that they bring to the clinic with them. For Black patients and families, there are specific cultural and different considerations that are have been explored. And a group at Yale in 2022 published their data after they conducted interviews with parents and adolescents who were affected by type 1 diabetes. The adolescents shared that the intersectionality of their multiple identities, being Black, being a teen, being a person with type 1 diabetes, was something that was concerning to them and absolutely impacted how they navigated the world. That they often felt like they were lacking peer support from those who look like them, that they felt they had increased visibility due to devices with alarms, so had some hesitation for tech use, and then really wanted to be independent and really wanted to use them, but didn't feel they had the experience, knowledge, or support to make complex decisions. Similarly, the parents reported having a lack of community as a barrier to why they may pursue diabetes tech, that they felt a lack of support both in and outside of the home, that they felt there was a lack of recognition of cultural differences, such as dietary habits and family dynamics from their clinical team that they felt were barriers to them pursuing technology. And then they also worried about just safety and efficacy and potential for acute complications. So the different domains of themes that emerged was really fear, family and culture, need for more exposure, mistrust. They also had some concern about financial barriers, and then the students talked about unwanted visibility. And we know that there is higher diabetes distress or higher negative mental health and psychosocial impacts on children with diabetes who are from Black or Hispanic backgrounds as compared to non-Hispanic white youth. And so that also probably largely plays a role in that as well. Researchers at Boston Children's conducted something actually quite similar in terms of evaluating the patient and family experience with their Hispanic population. And so between 2019 and 2020, they conducted interviews and focus groups with Hispanic parents of children with type 1 diabetes. They also shared about 4 main domains of different concerns, one being nutrition, with one parent saying is what happens is we have to educate ourselves all the time because food in the United States is so different from ours. It's a really big part of our culture, and changing it just to fit into the scope of diabetes care is really tough. They also voiced concerns about social isolation and feeling a lack of support of type 1 diabetes care, as many people are much more familiar with type 2 diabetes. One parent noting, for me, the hardest thing has been making my family understand her diagnosis because no one has type 1 in our families. Also, it's very culturally different. People are asking me, why can't you give her food? We're all eating. The third domain actually was deferential views of care experience and providers, meaning that families really actually appreciated their clinical team, but had some hesitancy to reach out to them between appointments. So there was an overall positive feedback about the diabetes team, but they did express a fear of being misunderstood and being seen as overusers of healthcare if they were to reach out between appointments. And finally, there was just kind of a general hesitancy to embrace diabetes technology because though many had a positive perception, they also worried about increased visibility and embarrassment for their kids. So what can we do to be culturally sensitive? Well, first is just recognizing it and understanding your population, talking to your patients and families about what they need and what their life is like and how we can make diabetes fit into that versus the other way around. It's also important to recognize that intersectionality that some of those students talked about and help patients and families create community. So thinking about group-based care, shared medical appointments. Peer and parent empowerment is obviously very important as that was shared as something that was desired by both groups. So maybe having culturally tailored nutrition classes or support groups with other families are areas of opportunity to help these patients and families feel more supported in their true selves. We all know that insurance is a huge barrier, so I probably don't need to spend too much time on this. But Medicaid, especially for many of our patients who are covered by Medicaid, can be a huge barrier and has very specific criteria for who they will even approve different types of tech for. For CGM here in Kentucky, the criteria is that you have to be taking at least one insulin injection per day. So for our patients with type 1 diabetes, unless they're in a very robust honeymoon phase, we're typically able to get that. But for patients with other types of diabetes or with other blood sugar concerns, this becomes a huge barrier. We know that high cost, poor coverage equals poor outcomes. And there are lots of different data on the effect of socioeconomic status, the low use of tech in patients who are in the lowest socioeconomic quintile, and the high cost of insulin with ongoing costs that are rising has been a huge problem. So what can we do to help address those barriers? Truly making advocacy a part of our routine medical responsibility is something that's very important. So speaking to our legislation and speaking to our patients' experience and advocating for the passage of any of the hundreds of bipartisan bills that have been promoted or proposed is a great place to start. Another is to partner with different type 1 diabetes advocacy and support groups so our patients can see us and so that we can educate ourselves better on their experience. The other is to just operate with objectivity. Of course, we know that Medicaid does have certain limitations, but things do change all the time. So making sure that we're not preemptively presuming that the answer is absolutely no, and that we're working with our amazing clinic team to try to figure out different methods of getting things approved for patients is really important. So maybe creating dot phrases for certain diagnoses and certain types of tech, having posters or family handouts so that people are aware and can advocate for themselves is really important. Can also advocate within our own institutions for patient-assisted programs, and then partner with device companies for sample provision and assistance programs. Another way that some institutions in some states have really done large-scale methods to address socioeconomic bias is establishing and leveraging accountable care organizations known as ACOs. So these are large-scale organizations that are composed of doctors, hospitals, healthcare workers, and healthcare systems that are coordinated to provide high-quality patient care, specifically for those with Medicaid. And the oldest and largest example of this is actually Partners for Kids, which is located in Ohio and out of Nationwide Children's. And so Partners for Kids has a couple different methods of helping patients and families to ensure that they're getting the most out of their medical care and are not falling victim to some of those disparities that lead to inequities in outcomes. So there's care navigation, where they're linked directly with someone who will help them navigate the system, especially for those with complex medical conditions. And then there's care coordination, where they're given a liaison who they can preemptively reach out to and who also may help them with gentle reminders on keeping themselves accountable, keeping themselves up to date, having that resource to ask questions and to keep themselves accountable. It has been overwhelmingly successful across primary care and subspecialties in terms of reducing inpatient days and hospitalizations, as well as acute care utilization. And so while we're working towards healthcare justice and legislation, these are great opportunities, though large scale and take a lot of coordination, to really help our patients and meet them where they're at to improve their outcomes. So really, it requires us to go from the top down, from public policy to addressing social determinants of health, to mitigating our own biases, to working with our families for us to really improve these diabetes outcomes. And finally, education, support, and ongoing follow-up are really important to success with diabetes tech. We see our patients every 3 months because for kids, 3 months can really be a lifetime. They grow, they develop, they go through puberty, they're in different sports seasons, their needs are constantly changing. So it's not inappropriate to assume that if someone's not coming to clinic, we're missing those opportunities to provide them with that, with those additional touches, that additional education, and those opportunities to help address any challenges they're having. So there is a presumption that populations that typically do not come to appointments are the ones that are struggling the most, and that some of the onus is on them. And while there may be some truth to that, some studies have shown that actually patients from populations that typically that have typically not followed up with the recommendations, non-Hispanic, Black, and Hispanic patients actually complete their CDE, so their Certified Diabetes Education, dietitian, and social work follow-ups more than other populations do. So these researchers felt that poor outcomes really weren't due to lack of follow-up, and did some follow-up questionnaires, some small group discussions, and some interviews with families, as well as their own staff. And what they conclude have persistent and efficient rescheduling efforts with kind of a scripted approach that really showed the care and empathy that the clinic had for the patients, that they improved equitable appointment attendance across groups. They also found that patients shared that they had some lesser engagement with staff and clinicians, and they concluded that this was probably due to the poor diversity of representation in the endocrine workforce and maybe a lack of emotional connection, as patients are only really seeing us in clinic and not in other settings. So what can we do? Well, education, engagement, representation are all key. So maybe making a concerted effort to connect with and interact with patients and families outside of the clinical setting will engender feelings of connections. So having events for families, going to JDRF events, having different walks, having events for families, all those kind of things may actually help to improve this. Efforts to diversify the clinical workforce, support staff, and then create peer mentors is also an opportunity to help patients feel more represented and seen. Engaging with community health workers has been proven to be cost-effective in a strategy to help improve diabetes control. And these are, again, people who will be in their space and act as liaisons between the clinic and the families, again, increasing that feeling of connection. And then always being aware of some of the underlying etiologies of disparities and making sure that we as clinicians are not only aware of them, but are addressing them, including that implicit bias and systemic racism. So we talked about diabetes technology and how it's advancing and the different stages of diabetes, because as we're moving on into these next couple of years, we're going to see the emergence of addressing stage 2 and stage 1 of diabetes, providing another opportunity for intervention, but also potentially another area of disparity. So teplizumab is actually the first FDA-approved immunomodulator therapy to delay the onset of stage 3 type 1 diabetes, fulminant type 1 diabetes in patients with type 2. So this is a humanized anti-CD3 monoclonal antibody that was FDA approved for ages 8 and above who have stage 2. So positive antibodies, dysglycemia, but not yet fulminant diabetes. It is given as about 30-minute infusion for 14 successive days. Its mechanism of action is to try to preserve beta cell function by enacting agonistic activity on T cell receptor CD3 complex to try to help with anergy and apoptosis, as well as reestablishment of immune tolerance. There definitely are some side effects of this infusion and lots of considerations of approaching this infusion, but it has been effective and shown to prolong the onset of type 1 diabetes up to 2 years in those enrolled in the initial studies. So the measure is a C-peptide level after a mixed meal tolerance. As I mentioned, there will be future advancements in type 1 looking at ability to mitigate progression of stage 1 and stage 2 diabetes. Some of those studies include T1D Relay, which is the rituximab abatacept newly diagnosed study, which is hoping to delay the progression of stage 1 and stage 2. The Jackpot T1D study, which is the JAK inhibitors newly diagnosed studies, which is hoping to eventually get to a place where they can utilize these medications to prolong the honeymoon phase for those already diagnosed with type 1 diabetes, and the TOPPLE study, the tolerance using plasmid studies, which is hopeful to retain immune system and stop beta cell attack, again, in those with recently diagnosed diabetes. So a really interesting and exciting time in diabetes management, because not only do we have increasing and further emerging available treatments for our patients who are affected, but potentially have solutions to prevent the onset or prolong the initial stages before progressing to full diabetes. So we've talked about diagnosis, we've talked about treatment, we've talked about the pathway to success, some of the factors that impact it, and then future directions. But one thing we haven't talked about is our audience, our primary care friends. So what is the role of primary care in T1D management? So screening and diagnosis. Though about 50% of our patients present in DKA, the other 50% don't and are caught by astute clinicians in their primary care setting who bring up newer concerning symptoms or who take a great review of systems and have a high index of suspicion. So that will remain a mainstay and a super important part of our care because the more we can prevent DKA, the better. It's also an opportunity to help families kind of recognize what type 1 diabetes care will be. And so just having some basic knowledge about how we care for our patients, knowing they're going to be in the hospital for us with 2 days, knowing that there are treatments, kind of giving them reassurance as you know them best is also really important. And then recognizing that when you make that diagnosis, it's urgent emergent and send them on over to Children's or their nearest emergency care. In terms of treatment, though may not be directly involved in treatment and modifying insulin doses, there are opportunities to just check in with families, see how they're doing, encourage them to pursue diabetes technology when you see them for those well-child checks, and then just recognizing that there are a huge variety of devices. And so someone that maybe in the past maybe a patient that may not have been successful or may have thought to not be successful with tech may have an option that works really well for them. We always encourage our patients to continue to see their primary care for routine follow-up, but then also for any other concerns. We see them every 3 months, and though we are the experts in their diabetes, we are not the experts in everything. So we really continue to remind them of the importance of those annual well-child checks and keeping that medical home. And again, at those well-child checks is an opportunity within the busy schedule and all the things that need to be done to just check in and see if they've had a diabetes appointment recently, what their A1C was, just so you kind of have an understanding of how they're doing. Also an opportunity to do screening for social determinants of health and mental health, which we know do impact a lot of our families. During acute care visits, one thing to remember for our patients with T1D is helping them to remember to check their ketones and enact their sick day care. And if they're not sure about that or have questions, referring them to us by phone to help them through that. And then also reminding them to always have their glucagon, especially if they have a vomiting illness. Finally, as we do begin to approach these new interventions and immunotherapies, early intervention and collaboration in looking at studies is going to be super important between primary care teams and endocrinology. At present, there are lots of opportunities, and there's some upcoming studies that I shared. But one thing that is always going on is TrialNet, our international diabetes study, which enrolls patients who are primary relatives of patients with type 1 diabetes into different arms in order to help better understand the disease, but then also provide opportunities for early diagnosis, as well as research opportunities. So in summary, CGM pumps and hybrid closed-loop systems have been shown safe and effective in reducing hypoglycemia, improving time and range, and enhancing quality of life. Uncovering and addressing the multi-level barriers to equitable type 1 diabetes tech requires recognition of systemic and individual factors, including implicit bias, prescriber bias, geographic and insurance bias. Advocacy, QI, ACOs, institutional and school-based interventions have been effective in mitigating various barriers. And collaboration between primary care and endocrinology is imperative for successful management, especially given the emergence of new therapies and trials. Thank you all for your time and attention, and I welcome any questions or discussion.
All right, thanks, Dr. Wood. So in your short time here, have you planned research for addressing inequities in our surrounding area?
Yeah, so I have met with our team here at Novak, who are already very much engaged in school health in thinking of ways that we can further optimize that to directly reach our students. I'm going to be our medical leader for our DART clinic, so our diabetes advanced therapies clinic that is designed for our patients who are the most vulnerable, which is currently led by an amazing team, including social work, clinicians, and diabetes educators who are providing monthly care rather than every 3 monthly care. And so we're working to think about ways that we can further optimize both adherence with that clinic, connectivity within that clinic, but then some of the ways that we're intervening with those specific populations. And I've also been seeing patients and will be seeing patients at the West Louisville location, which provides us an opportunity to both engage one-on-one with those patients in a place that's closer to their home, but then understand what their needs are and develop QI interventions and partner with community organizations to really tailor their needs.
All right, great. I know diabetes is certainly a target for gene therapy and as other things have been, but I encourage you all to think about it proactively and how to implement it when it's out, because I've unfortunately, I don't think it's been very fast in other things like sickle cell, et cetera. So, all right. Well, thank you for everything, Dr. Wood, and everyone, thank you for joining us today.